Okay, let's settle in for a deep dive today. We're focusing on a really high-yield topic, especially if you're doing any medical revision, maybe prepping for exams like the MSRA.
That's right.
We've pulled together the key info on Keratoacanthoma, the mission, really just unpack the essentials you need to know.
Exactly. Think of it as um, getting straight to the core facts. Will cover what it is, what might cause it, who gets it.
And crucially, that relationship with other things, right?
Yeah,
Especially squamous cell carcinoma.
precisely. And how we manage it.
Yeah.
It's often confused, so clarifying those points is, well, vital.
Okay, good. So this is like a focused revision session, quick but thorough, making sure you're exam ready on this.
And you mentioned the key challenge already, that confusion with SEC. They can look strikingly similar sometimes.
Definitely a pitfall.
Okay.
Let's unpack keratoacanthoma then, starting right at the beginning. What is it, fundamentally?
Fundamentally, it's a dome-shaped skin tumor, and specifically it arises from the cells of the hair follicles.
Right, hair follicles. And there's a really critical piece of context here, isn't there? That it's often thought of as, what, a low-grade SECU?
Yeah, exactly. It's considered a low-grade variant or a form of squamous cell carcinoma. And visually, when it's sort of fully formed, it has this classic look.
Describe that look.
Usually a single lesion, it's raised up, firm borders. And the real giveaway is that central crater. It's typically filled with keratin.
Ah, yes, the volcano description. I've heard that. It's quite memorable.
It really is. It's sort of rapid growth, which we'll get into, and that central crater.
Yeah.
It does look a bit like a small volcano. It's a key visual.
Okay, the volcano tumor from hair follicles linked to SCC. Got it. So why does it happen? What's the etiology?
Well, the honest answer is the exact cause isn't fully pinned down. It's likely multifactorial.
But we have some strong suspects, right? Like chronic UV exposure seems major.
Absolutely. Especially in people with fairer skin. That's a big one.
And I think trauma's mentioned. And maybe viruses like HPV, immune system issues too.
Yes, all those factors have been implicated. Trauma to the skin, certain HPV types, and immune dysregulation definitely seem to play a part.
And that link to SCC comes up again here with the causes, doesn't it?
It does. Many of the same factors, particularly that heavy UV exposure, are implicated in SCC development too. It highlights that biological connection, you know.
So given those causes, who should we be thinking about as being more at risk?
Well, the typical profile involves definitely significant sun exposure history, fair skin types, as we said, and older age is a big factor.
Older age. And is there a gender difference?
Yes, it's seen more often in men, roughly twice as often as in women.
Okay. And what else? I think the list includes people with a history of other skin cancers.
Correct. Also, certain rare genetic conditions like xeroderma pigmentosum put people at higher risk.
Weakened immune systems too, maybe from illness or medications.
Yes, immunosuppression is a factor, and also previous skin trauma at the site where it develops.
And there's a genetic predisposition more broadly, and even some occupational risks, like industrial workers exposed to pitch or tar.
That's right. And it's striking, isn't it, how much that list of risk factors mirrors the list for squamous cell carcinoma.
It really does hammer home that connection. Okay, let's go a bit deeper, maybe to the cellular level. What's the pathophysiology? What's actually happening?
So what we're seeing is abnormal proliferation of cells. But it's usually kind of contained,
Right.
originating from the pilosebaceous unit, that's the hair follicle, and the oil gland connected to it.
And it's a mix of things driving that: genetic changes, sun damage, immune factors.
It seems to be a complex interplay, yeah. Those genetic mutations, the UV damage, the way the immune system responds, or maybe doesn't respond properly.
But the exact mechanism isn't fully clear.
Not entirely, no. But the key thing from a clinical perspective, the bit that really defines its behavior, is that growth pattern.
Right, that rapid growth phase.
Exactly. Rapid growth initially, and then this tendency, quite unique, for it to spontaneously regress, to shrink away on its own.
Which brings us neatly to maybe the most critical bit for exams and practice: the differential diagnoses. What else looks like this?
This is so important because it grows fast and has that dome shape. Lots of things could be considered.
Top of the list has to be SCC, right?
Absolutely. Number one differential is squamous cell carcinoma, but you also need to think about basal cell carcinoma.
Okay.
Maybe actinic keratosis, particularly the thicker hypertrophic kind. Even things like seborrheic keratosis sometimes, or molluscum contagiosum in some cases.
And the source material really stresses how hard it can be to tell Ka and invasive SCC apart just by looking.
It can be incredibly difficult. Clinically, they can be lookalikes.
Let's try a quick scenario. Imagine, say, an older man, fair skin, lots of sun exposure over the years. He shows you a lesion on his forearm, says it popped up fast, maybe grew over the last 6 weeks. It's firm, dome-shaped, bit of crust in the middle. What's the diagnosis screaming out that you must rule out apart from KA?
Yeah, squamous cell carcinoma, that's the one you absolutely cannot miss.
Exactly. That scenario fits both perfectly, underscores the point. So, linking that clinical picture to the population risk, tell us about the epidemiology. Where do we see it most and in who?
Well, unsurprisingly, given the link to sun, they are most common by far on sun-exposed areas of the skin. Face, neck, forearms, hands.
And how common are they overall?
They're relatively common. In the UK, estimates suggest they make up something like 5 to 15% of diagnosed skin cancers. The incidence is around 1 in 1,000 people per year.
Okay, 1 in 1,000.
Yeah.
And the age group?
It definitely skews older. The incidence really picks up after the age of 60. You see it most often in the 7th or 8th decade. It's pretty rare in young adults.
And less common in darker skin types, presumably because of the UV link.
Correct. Uncommon in darker skin. And as we mentioned, about twice as common in men compared to women.
Right. Let's lock down those clinical features again. We mentioned the volcano look. Talk us through the typical presentation.
Okay, so it usually starts small, a little firm papule or nodule, often skin-colored or maybe reddish.
And the key thing is the speed.
Yes, the defining characteristic is that rapid growth. It can get significantly bigger over just a few weeks, maybe up to 2 or 3 months.
Wow, that's fast.
It is. And as it grows, it develops that typical dome shape, the firm raised edges, and that central crater that fills up with keratin debris. Looks like a plug sometimes.
Is it usually painful or itchy?
Generally, no. Mostly painless. Some people might report a bit of tenderness or maybe some itching, but often asymptomatic.
And locations: face, ears, neck, hands.
Exactly. Those high UV exposure spots are classic.
Yeah.
Face around the eyes, nose, lips are common spots. Ears, neck, forearms, back of the hands.
Now, that timeline, rapid growth, then what happens if you just leave it? You mentioned regression.
Right. So after that growth phase, maybe a few weeks to a couple of months, it often enters a kind of stable phase. And then typically after about 4 to 6 months, though it can sometimes take up to a year,
It starts to shrink.
yeah, it begins to spontaneously involute or regress. Keratin plug might fall out, it flattens, shrinks down.
Then leaves what behind?
Usually leaves a scar, often a bit pitted or depressed. Can be cosmetically significant depending on the location.
But here's the crucial point, right? Despite this tendency to self-resolve, we don't just watch and wait.
Absolutely not. And this is critical, because telling it apart from an invasive SCC clinically is so unreliable. Urgent excision is often the recommended path.
Even if you suspect it might be a KA, that would go away on its own.
Yes, because while a true KA very rarely metastasizes or causes death, an invasive SCC absolutely can. The risk of misdiagnosing an early SCC as a KA and delaying treatment is just too high.
Okay, that makes sense. So if clinical judgment alone isn't enough, how do we confirm the diagnosis? Investigations.
Biopsy is the gold standard. You do tissue to look at under the microscope.
What kind of biopsy?
To really tell the difference between KA and SCC, the pathologist needs to see the architecture of the lesion. So you usually need a good chunk, either a full excisional biopsy where you take the whole thing out, or at least a deep incisional biopsy, taking a decent wedge that includes the full thickness of the lesion and some underlying dermis. A superficial shave biopsy is generally not enough.
Okay, so a substantial sample is key. Any other lab tests that help?
Sometimes the pathologist might use special stains, immunohistochemistry, to help differentiate it, especially if the features are a bit ambiguous under the microscope, but that's more for the lab side.
And imaging, scans?
Generally not needed for a typical KA.
Yeah.
Only really considered if there's a very unusual presentation or a suspicion of deep invasion, which again is rare for KA itself.
Got it. Biopsy is king. So once you have that diagnosis, or even if you just have a strong suspicion, what's the management approach? Let's think about the UK, maybe NICE guidance or NHS practice.
Well, as we've been saying, even though spontaneous regression can happen, the standard approach, driven by that difficulty in ruling out SCC, is surgical excision.
So cutting it out is usually step one.
Yes, complete surgical excision with clear margins is the preferred treatment. It achieves both diagnosis, allows the pathologist to examine the whole lesion and treatment at the same time.
Makes sense. Are there other options? Say, if surgery is difficult, or maybe someone has lots of these lesions?
Yes, there are medical treatments for situations where surgery isn't the best option. These can include things like Systemic retinoids pills like isotretinoin,
Okay.
or injecting medication directly into the lesion. Things like methotrexate, 5-fluorouracil, bluamycin, even steroids have been used intralesionally.
What about creams?
Topical treatments are also an option sometimes. Creams like imicamod or 5-fluorouracil can be used.
And presumably you'd be referring these patients
Oh,
to derm.
absolutely.
Yeah.
Suspected KAs should generally be referred to dermatology or perhaps plastic surgery, depending on location and local pathways, for confirmation and management.
And prevention, going back to the causes, it's mainly sun protection.
Yes, fundamentally. Sun avoidance during peak hours, protective clothing, broad-spectrum sunscreen, general sun safety advice is key for prevention.
Okay. Looking beyond treatment, what's the typical outcome? The prognosis.
For a straightforward keratoacanthoma, the prognosis is generally excellent.
Because they often go away on their own.
Exactly. Spontaneous regression is common, and once it's resolved or excised, that's usually the end of it, apart from the scar.
But there are always buts in medicine. Are there exceptions?
There can be. While rare, some lesions might just persist instead of regressing, or they might recur, come back after treatment.
And the big one, the SCC connection.
Yes, the most significant, though still uncommon, potential issue for a lesion definitively diagnosed as KA is the possibility of it undergoing transformation or progression into a true invasive squamous cell carcinoma.
So even if it's treated or gone, you still need to keep an eye on things.
Yes, regular follow-up and skin surveillance are generally recommended, just to monitor the site and check for any new suspicious lesions.
Which leads us straight into complications. What's the main worry?
The primary concern, the main potential complication, is that possibility of progression to invasive SCC.
So clinically, what should you be looking out for? If you're monitoring a patient who had a KA, or maybe one that wasn't excised initially.
Key warning signs would be any new enlargement after a period of stability or regression, or if it starts to ulcerate when it wasn't before, or simply if it just keeps growing beyond that typical few-month time frame where you'd expect it to start resolving. Persistent growth is a red flag.
Because those signs might mean it's evolving into something more sinister.
Precisely. Detecting those changes early is crucial. It might trigger the need for urgent intervention like excision to prevent deeper local invasion or, very rarely, spread.
Okay, so wrapping this all up, what does this mean for you listening, maybe revising this topic? We've covered a lot.
We have. We've looked at Keratoacanthoma's identity, that volcano tumor from hair follicles. It's linked to SCC as a low-grade form. The risk factors like sun and age. That unique pattern of rapid growth, then potential regression, what it looks like.
Yeah, and how vital biopsy is for diagnosis, why surgery is often preferred because of the SCC mimicry, the generally good prognosis, but also that small risk of progression.
So the absolute key takeaways for revision. Number one, recognize the classic volcano-look dome-shaped central keratin crater. Number two, remember the rapid growth over weeks to months.
Not years.
Exactly. Number three, understand the relationship with SCC low-grade form, but hard to distinguish clinically. Know the main risk factors: sun, fair skin, age, male gender.
Number four.
Biopsy is essential for definitive diagnosis, need a good sample. And number five, surgical excision is usually preferred to rule out invasive SCC.
Got it. So here's a final thought to consider. Even though these lesions often just disappear by themselves, the fact that they can potentially change into a dangerous cancer and look so much like it initially, well, it really highlights why you can't be complacent, why thorough examination, high suspicion, and getting that tissue diagnosis are just fundamental in dermatology. Remember, this has been a high-yield deep dive into Keratoacanthoma designed to streamline your revision. For more free MSRA revision resources, you can visit freemsra.com, and for the full premium revision toolkit, head over to passthemsra.com.